Subscribe to our YouTube channel and press the bell icon to get the latest updates.
I'm with Dr. Srinath Reddy, the President of the Public Health Foundation of India, one of India's leading epidemiologists, and Dr. Faisal Mahmood, the Associate Professor of Infectious Diseases at the Aga Khan University in Karachi in Pakistan. Welcome to you both, gentlemen. This is ThePrint Debates, and we're discussing the India-Pakistan story on COVID and how both countries have handled the COVID situation. Thank you very much for joining me.
Thank you for having us.
Dr. Reddy, first of all, if I may ask you, it's been 7 months since Prime Minister Narendra Modi on the 23rd of March announced this big lockdown across the country, almost 7 months, one week shy of 7 months. And for the first time, if you look at the data, it seems as if India is bending or flattening the COVID curve. But your first comments, and if you could just explain what this means.
While it appears to be 7 months sequentially on the calendar, we must recognize that we have gone through different phases. We have had a tight lockdown initially, then a relatively loosened lockdown from the 3rd of May, and then the lifting of the lockdown in various phases, and almost complete absence of the lockdown from beginning of July onwards, except in a few places in India where it was extended to end of July.
Right.
And therefore, we have actually seen the pandemic advance both in terms of different phases of restrictions and also geographically from the large cities and the surrounding districts to other places in India now. And each with a different calendar. It would be difficult for us to say that all of India has had a 7-month calendar in terms of the epidemic, though in terms of the lockdown, yes, the clock began 7 months back. But in terms of the virus, which doesn't keep note of that particular clock, it has progressed at different phases in different parts of the country. And now we are seeing that in the big cities and in the surrounding districts where it started off initially, we are seeing now the case count come down. And more importantly, from my point of view, the daily death count come down. And that is a sign that at least here, in those places where the epidemic began, we have gained control. Whether we will continue to do so in other parts of India, we'll have to keep a watch. And we'll also have to wait for other events that might actually give the virus a free rein again in the coming months.
Right. Dr. Faisal Mahmood, we know, you know in Pakistan and we know very well in India how the virus behaves as it wishes. It doesn't brook any challenges, whether rich or poor. It doesn't really care about socioeconomic strata. But let me just some very, very bold statistics, and which seem quite interesting. But I would like you both to explain to me and give me and put some more meaning into this. If you just look at the statistics, India's deaths are in the region of 1 lakh plus, which is 1,03,600 odd cases, while Pakistan's deaths, and I'm quoting figures from the Dawn newspaper, are 6,513. Also, but I think in terms of cases as well, India is much higher. Obviously, India's population is much higher, where 138 crore people. Pakistan is about 23 crores. But your first comments.
So there does seem to be a stark difference, but I think one really important point that you pointed out is the population size. So it's really a difficult comparison given the fact that India's population size is much bigger than Pakistan, and also India has a lot more cities which are more densely populated as opposed to Pakistan. We only have 4 or 5 cities, and as was just mentioned, this is a disease which really travels first in the urban and then goes in the rural areas. So the number of people potentially to be infected was obviously much higher in India to begin with, and that's I think what you're seeing in the numbers. And with the raw numbers, obviously the other problem that we got to always factor in is the amount of testing being done. India is doing per capita more, or per population more testing than Pakistan is, and that's why I think the death rate tends to be a better marker in some ways, or more objective of the number of disease cases that you're seeing in the population.
So why is, Dr. Reddy, to you, if India is testing, say, 64,000 tests are being conducted per million, Pakistan is much, much lower. Why do you think that is? And, maybe we can make some comparisons with Uttar Pradesh, which is also like a 200 million population, just like Pakistan. So comparably, not just in population, but also in terms of socioeconomic strata, whether it's female literacy, maternal mortality or infant mortality deaths. But Dr. Reddy, to you, why is it that India is testing so much more, even UP and Bihar, and I'll give you the figures, but first your comments.
Firstly, it depends upon the indications for testing, and secondly, the availability of testing kits and the ease of testing. Well, we also did have very low numbers to begin with, and we had fairly restricted indications for testing. Then we started liberalizing the testing quite a lot as the testing kits became available and private labs were allowed to do it. And now even on-demand testing is permitted now. Mm-hmm. But more importantly, I think the availability of the rapid testing kits gave it a much greater fillip in terms of the ease of testing. And testing became much more extensive across the country, not just in the big cities. So I think our testing numbers have risen quite a lot. But I think we also ought to look at the test positivity rates. Mm-hmm. If the test positivity rates are rather low, then it means that the testing is still fairly adequate, though it may still be that people who are tested negative may still be harboring the virus because of some of the false positives. Sure. But still, the test positivity rate is one number we should be looking at, rather than just looking at the testing numbers themselves because of this mixture of tests and the variable composition of the testing criteria.
Mm-hmm. Dr. Mahmood, I was just looking at some UP Bihar figures. UP has tested about 108 lakhs, so just over 1 crore tests so far, while Bihar has tested about 77 or 78, say around 80 lakhs or so. But I think, and the Bihar's population is 12.5 crores, which is half of Pakistan and half of UP as well. But Pakistan has tested really low. It's about 36.5 or 37 lakh tests only.
So I think it's exactly what was just mentioned. Again, it's also it's a number of things. It's a test indication. So we actually had started private lab testing pretty much earlier, as soon as we started getting tested. So it was actually a private-public partnership. And actually, the government had been using private labs to do the testing to increase their capacity as time went by. However, the one big difference is that a majority, and actually almost exclusively the tests which are being done are PCR tests.
You are doing RT-PCR tests?
We are doing RT-PCR tests, not the rapid tests. Okay. So the RT-PCR test, there's a limit of how many you can do, set not just by the availability of the kits, but also the time it takes to do the test, the transport of the test to the lab, and doing and sort of collecting the sample also. While the rapid tests can often be done on the field, they're much faster, more rapid, and you can really expand rapidly. And I think that's the one really big difference between the testing strategy between Pakistan is which test kit you're using. This does obviously mean that there'll be a slightly higher false negative rate in India, which would mean that you may miss people. But if I take off my clinical hat and put an epidemiological hat, so the reason we're doing testing in the community is to prevent transmission, and the test does really well when you're really infective. When you're not so infective, it doesn't work as well. So I think the antigen test is probably the way to go, and that's the reason why in the country, in Pakistan also, we're now going to be moving to the antigen tests to sort of shore up our testing at this point, because we're pretty much testing at capacity, and capacity has been enhanced quite a bit. In terms of test positivity, and that's a really good point, because it's not just the total number of cases, but the test positivity. And our test positivity is about 1 to 2%, which is not bad. I mean, compared to really high, but there are some provinces with a very high test positivity rate, which obviously indicates that testing could increase.
Like which, the line is not clear at all, unfortunately, but if you could just tell us a little bit about which provinces are doing better than the other. Pakistan, of course, has 4 provinces, Punjab being the largest, but tell us a little bit about how these provinces compare with each other.
So the larger provinces and the more developed provinces, so Punjab, Sindh, they actually have fairly low test positivity rates at about 1 to 2%. Some of our more smaller but less developed provinces, and this would be Gilgit-Baltistan, or they actually have a much higher positivity rate. And this also has to do with the logistics, because these are really not very densely populated. People live far, in the mountainous areas. Getting to them is tougher. And a lot of these testing that is being done there is symptomatic testing. So people get sick and they go to the doctor and they get tested, as opposed to in the largest cities where testing is being done, as surveillance also, and hence your positivity rate is lower.
So, Dr. Reddy, if Pakistan has got one, and the point that you made about test positivity rate, if it's 1 to 2%, as Dr. Mahmood is pointing out, India's has fallen considerably. In fact, over the last 24 hours or so, the figures are that the test positivity has dropped to 5.1%, which is the lowest in 4 months.
Well, it's true that our test positivity rate is higher, because I think the number of persons being infected are also higher. We must recognize that infectivity is partly a factor of urbanization and crowd density. And having a larger number of urban areas, particularly where the initial international airports brought in large number of travelers, then the surrounding districts, and then the subsequent dissemination across the country, I think the degree of urbanization and economic development also has a certain influence on the number of people who get infected in terms of the viral transmission dynamics. Therefore, it's not surprising that some of our big cities have been infected quite a lot. But we also have to compare ourselves not necessarily with the South Asian neighbors, all of who seem to be doing relatively well on death rates, but the big cities elsewhere in the world. And if you do that and take the deaths per million rather than cases per million, it's interesting that Calcutta has currently 125 deaths per million, Ahmedabad 254 deaths per million, Bangalore 269 deaths per million, Delhi 302, Chennai 309, Mumbai 463. Compare that with Paris 679, London 768, Washington 1031, and Madrid 1409. So essentially, when you compare the big cities with big cities elsewhere in the world, we are not doing terribly badly in terms of the death rates per million. And that is the general feature in South Asia anyway. So in terms of the infectivity, certainly the population density, and which is also correlated with the level of economic development and international travel, sets us slightly apart from the other South Asian countries.
But what do you attribute this to? And this question is to both of you. Dr. Reddy, you first. Why is it that although the health systems in South Asia are far worse than those in the West, but those in the West, at least from the figures you cited, shows that they're doing, at least, deaths per million are far worse, if not 2 or 3 times worse than what you have in several cities in India?
Well, we certainly have the advantages for younger population. All the cities I've mentioned in comparison with the West have much older populations. And therefore, at that end of the spectrum, you have people with many more risk factors. Of course, we do have cardiovascular risk factors and diabetes, even in our middle-aged population. But nevertheless, taking the entire population into account, the percentage of people who are aged and have associated comorbidities is much higher over there than here. So I think that is one important area. And if you take the country as a whole and not just the cities, the fact that 2/3 of India's population is rural, where the spread of the virus is firstly slow and the level of comorbidities are much lower than the urban areas, also gives us a level of protection. Whether there are other factors, we really can't say at this point in time, in terms of our BCG immunization and also whether our diets are likely to be much more fiber rich. There are some interesting theories coming up that our microbiome may be different, or whether we are just also much more exposed to a number of infections which have actually given us a better both in adaptive immunity status.
Mm-hmm. Dr. Mahmood, you live in Karachi, and Karachi's population is enormous. I mean, it compares to Delhi, right? About 20 million people or so. But having said that, you're saying that your strategy is now moving towards a rapid antigen testing strategy, which we all know that the false positives in the antigen testing are far higher than the RT-PCR. So what do you attribute this to? Is it that the state doesn't have that kind of money, or what is the reason?
So I think, and I'm just going to echo one thing that Dr. Reddy has mentioned is I think our younger population, I think, is really what saves us in terms of death. But there is also one other thing, which is the patient management in Pakistan and also probably India was a little bit better in the sense that the disease came later than the rest of the world. So we didn't have to experiment and learn. We already had a lot of the data coming into us. And we, our initial mortality was actually higher, and then it went down as data came in much faster in terms of what works and what doesn't work, and B, as we got better in treating patients. So always keep in mind that the proficiency of the treating physician makes a difference. In terms of antigen testing, we're now going to move from an RT-PCR to an antigen testing strategy, but it's going to be supplemented. So areas where we need to test more frequently, for example, schools which are reopening, areas where...
Are schools reopening in Pakistan?
Schools have reopened in Pakistan, yes, already.
Across the country?
They have, but not in the normal sense. They've opened in a staggered form. So all classes don't come in at the same time, and it's sort of a hybrid online and offline school. And then school get 5% of the school population gets tested on a periodic basis, which is almost every 2 weeks, which for me is too late, which is why an antigen test would actually help us do much faster testing or much faster within these schools.
So your voice broke at the time, but did you say that 5% of children going to school are being tested on a daily basis? Is that correct?
No, on a 14-day basis, every 2 weeks.
Every fortnight, okay.
Yeah, it should ideally be every week, if not even more rapid.
Mm-hmm. Okay, so Dr. Reddy, what do you think? Do you think that it's the time, unlockdown in India is now, we're almost back to what we were pre-COVID, pre-lockdown, but schools haven't opened yet. What do you think? Do you think they should open?
Well, I think we have to live with this virus as a challenger for quite some time, and we cannot completely freeze all our activities, whether economic or social or scholastic. But we have to be very cautious in the manner we do it. One of the most important things is to prevent basically super spreader events in indoor places as well as in outdoor crowds. Mm-hmm. And if we can actually open up our schools in a staged manner and also have differentiated school hours for different batches so that we prevent overcrowding and practice as much ventilation in the schools as possible, because it's absolutely very clear that that's going to be protective, then we can actually open up our schools. And particularly in rural areas where most of the schools are well ventilated, it should not be too much of a problem. But we must indeed ensure that masks are worn, and that kind of protection also must be kept in mind. So for quite some time to come, we'll have to live with these limitations, but that will give us the benefit of resuming some semblance of normal life, and scholastic activities are a very important part of that.
So, Dr. Mahmood, I need to ask you this. Your Prime Minister Imran Khan some days ago, and just about a week or so ago, talked about how Pakistan had implemented this very smart lockdown, and he was very disdainful of India, actually, because he said, India's figures are so high, they have this sort of massive lockdown, and it hasn't helped, the economy has crashed. I mean, the economy has crashed, it's sort of 10% of the GDP has sort of been wiped out. But what do you make of Imran Khan's comments?
So I mean, I don't speak for anybody. I speak for myself. You can't make any comments that way. But we did move from a complete lockdown to a smart lockdown, or actually a better term would be a localized lockdown state. And the implementation of this varied between cities and cities. So some cities were able to do this more effectively, while others were not, depending on the infrastructure of the city itself. So, but I think it's the comparison between the two countries is a lot more complicated than one intervention. I think it's multiple things happening multiple times, and it's in some ways, even though they're neighbors, it's almost apples and oranges in comparison.
So we talked about some of those apples and oranges in terms of, population, test positivity rate, the numbers of the test itself. But I also wanted to ask you, Pakistan and China have such a close relationship. You describe it as higher than the mountains, deeper than the seas, and sweeter than honey. And China has actually dealt with COVID really well. I mean, they shut down Wuhan at the beginning for 76 days. It was this really tight shutdown. So has Pakistan learned from China? Have they helped you with interventions, with showing you how to do things?
So yes, early on, and still now, China did help us quite a bit in terms of both giving technical advice, helping us with increasing our testing capacity. In fact, the initial testing kits had come from China, which helped sort of kickstart our testing of SARS-CoV-2 within the country. But you also have to keep in mind that each country, whatever they do, has to be tempered or looked at in their social circumstances. I think what China did with this massive lockdown of a whole city, very few other countries can do that. Very few governments have the machinery in place already to put that sort of a lockdown in place. And then keeping in mind, once the cat is out of the bag, a lockdown really is just there to buy you time. This virus will spread to the population eventually, and you just want to slow down as much as you can while you get your vaccines and your healthcare facilities up to mark. But yeah, there's no doubt China helped quite a bit, both in terms of technical advice, providing us with kits for testing, and PPE as well, actually.
But they didn't send any doctors, did they?
No, we had teams of doctors coming in also, not working in the hospitals, but sort of giving us training to some extent in case management.
Dr. Reddy, what do you think? Why has, I'm sure that other countries would have volunteered both sort of physical resources as well as, doctors and healthcare workers. Do you think that this question doesn't come up in India because we have our own sort of army of doctors and healthcare workers, or is it that people must have offered and we said no?
I think in March, April, every country in the world was struggling to find its own resources internally. Even the high-income countries were failing to get the number of test kits, the equipment, and there was also a shortage of health workers, whether for contact tracing or even in hospitals, nurses and doctors either falling victim to the virus or suffering from fatigue and exhaustion, attrition on all counts. So I don't think that level of international cooperation would have really happened at that time. But we did use that time to ramp up our own internal resources and organize our systems much better. So that by the time June arrived, we were in a much better position in terms of testing kits, hospital beds, though we still have a great shortage of health workers, particularly in primary care, and even district hospitals are not very well equipped, including with oxygen supply. But I mean, we are running short of oxygen in some places. But nevertheless, I think we did ramp up our capacity quite substantially to be able to cope with this. And now look at Europe, it's having its second wave. Where is it that they're going to be sending us any help? Yeah. It's only possibly some Southeast Asian countries who might have come to our support. But they did with some testing kits and other equipment.
Right.
But I think internally we are better organized now to meet our own needs.
Mm-hmm. Dr. Mahmood, you were the first, you treated the first COVID case in Pakistan. Now, describe to me the state of an average hospital, a public hospital, say in Karachi.
So in terms of COVID and the public hospitals, actually, and this is something that I always tell people that COVID in many ways also has a silver lining, because of this, public hospitals and units in public hospitals which were not really taken care of have now been ramped up, and they've got more ventilators, they've got more trained doctors, so at least from a COVID standpoint, things that the resources that were put in really had not been put in before. So in terms of public hospitals, I think we're not terribly. Things are much better than they were, at least from a COVID standpoint. But I agree with Dr. Reddy. There's still ways to go. If we hit a second surge, the biggest challenge we're facing at this point is that during the initial surge, the hospitals were empty. We were not seeing other patients. But at this point, hospitals are again full with non-COVID patients, and then struggling to find room for COVID at the same time, which is sort of the problem which other countries are finding at the same time. And we were just discussing this internally also this morning.
Right. So last question to the both of you, Dr. Reddy. There are lots of countries making their own vaccines, whether in the US, China, Russia. In India as well, we have a few. The Serum Institute in Pune is sort of trying to develop a vaccine. But do you think that there should be sort of, more collaborative efforts across South Asia? Or is this just one of those India-Pakistan things that because we don't like each other too much, we don't even discuss healthcare issues? The virus doesn't respect borders, does it?
No, it doesn't. And in public health in particular, I don't think we have an adversarial relationship ever with anybody else in the world. We leave political debates and differences to politicians and TV anchors. But as far as public health people are concerned, we believe in global solidarity for all of humanity. Therefore, I believe that we, having the strength in producing vaccines on scale and at low cost, whether it's going to be an India-developed vaccine or a vaccine commissioned for production in India, I think our ability to produce vaccines on a large scale will be very helpful for the whole world. And certainly even for South Asia, we ought to be able to provide as per need. Of course, it is for them to choose whether they want a Chinese vaccine or a Russian vaccine or an Indian-made vaccine. Those are decisions that will be taken by their policymakers. But I think making our vaccine available, once our own needs are being addressed, to the rest of the world, especially in South Asia, would be the appropriate thing. In fact, as you remember, in March itself, the Indian Prime Minister had convened a meeting for South Asian collective response and a collaborative response to the COVID virus, the COVID pandemic. Mm-hmm. So if that spirit of collaboration actually pervades and remains, then we ought to be really sharing resources and sharing knowledge.
But it hasn't happened so far, Dr. Mahmood. What do you think? Have Indian and Pakistani doctors been to epidemiologists or, whether at the level of the government or privately, are they talking to each other? You're probably looking at a Chinese vaccine, aren't you?
So, I think I completely agree with Dr. Reddy, is that, we're talking about two sort of different things. One is which vaccine to bring in, and then the second is where to get the vaccine from. And there's no doubt that, once a vaccine is decided, which is the vaccine to deploy within the population, where we're going to get this vaccine from and who's going to manufacture it, there's a good chance that India is the one manufacturing the vaccine, just because the ability to scale up production that rapidly.
But has this conversation started so far? Do either of you guys know whether there is any conversation like this about India-Pakistan collaborating, or India manufacturing a vaccine and then having other South Asian states access to it?
Not that we are aware of. Public. Go ahead, Dr. Mahmood. Pehle aap.
No, it's about my pay grade, this discussion. So
okay. It's about his pay grade. Dr. Reddy, you tell me.
Well, I think basically we are not seeing it anywhere in the media space, and it may not happen directly, but there are so many international agencies and channels, including the WHO, which can actually facilitate this kind of exchange.
Right.
So I'm sure there will be something going on at different levels.
Yeah, but apart from this Gavi solidarity trial that is ongoing, Dr. Mahmood, what's the vaccine that Pakistan wants? Do you want a Chinese vaccine or do you want any other one?
At this point, we're we're going to get a WHO pre-qualified vaccine. One meets the criteria for it to be efficacious. So it doesn't, so it's not the country, it's the vaccine which is more important.
Right. On this note, gentlemen, thank you so much. Dr. Faisal Mahmood in Karachi, Dr. Srinath Reddy right here in Delhi. Thank you both for your views. We do hope that the vaccine will come sooner than later so that we're sort of able to get back to our pre-COVID lives. Thank you for participating in the Print Debates, and please do watch us on the YouTube channel of The Print. Thank you. Thank you so much for this.
Thank you.